It is a great honor and pleasure to be with you again. And this webinar series was a fruitful effort of different universities and different institutions, North America, Canada, and the United States specifically, in addition to the great help from our great collaborators in Assiut University. So basically, we try to provide something easy to handle during the COVID-19 times. And also it's comprehensive enough in order to bring you up to date with the different topics of reproductive medicine and reproductive surgery. I wish and I hope that we remain true to our objectives, and just here reminding you quickly with the objectives of this course that we started with. That's our goal really is nothing but up-to-date knowledge, evidence-based facts, building on your already existing educational institutions in the Middle East, and particularly in Egypt. We wanted also to visit or revisit the areas of the specialty that are rather not looked after very carefully, like core endocrinology. And we also put some basic science touch with the possibility of knowledge translation. And more importantly, I think throughout the entire lecture series, we shared with you clinical pearls and practice steps that could be useful to you in your practice. Our target audience was very broad, actually, from medical students and up, residents, fellows, masters and MD students, practitioners, university faculty, basic scientists. Everybody would be able to find something that could be useful to him / to her attending either live or attending the recording of this series. And as I said earlier, this is a collaboration. The far left here, and most important, the Assiut University, the host institution for this activity. And from here, where currently I am, the University of British Columbia and University Hospitals of Cleveland, Ohio, and the Cleveland Clinic Foundation via their main campus branch in Cleveland and via their satellite branch in London, UK. We had a total of 12 webinars and 13 speakers. The average duration of each webinar was around 2 hours, with ample time for questions and answers that we shared with you. That's a sample of the first 4 lectures that you kindly attended, and I hope that you already have something to retain and to keep. And we are open for suggestions regarding any future scientific activities that will be using the Assiut University platform or any other similar platform that could be useful to people. I would like also to remind you that there are reading materials attached to almost all these webinars. If you are interested, communicate with the local team in Assiut University and they can share that with you. That effort can't be completed without the support of the University of Assiut administration and leadership at its highest level. I was over the phone with Mr. President, Professor Tarek Al-Jamal, actually yesterday or the day before yesterday. He was very supportive and he was very keen to applaud that effort. So I would like to thank him, whether he's in the audience or he will be watching this recording later. Would like to also thank my dear colleagues who are instrumental to the initiation, maintenance, and the delivery at a high quality of this course, Professor Mahmoud Abdelalim, Dr. Alia Haroun, and my dear colleague, friend, and Professor Omar Mamdouh Shaban. And that happened under the leadership of Professor Tarek Khallaf Hussieny, the current department head of Obstetrics and Gynecology in Assiut University, and his tenure as a department head is coming to an end shortly, and we wish him all the very best in the next step of his career. I am actually speechless when it comes to the support that we received from EBSA Pharmaceutical. specifically Dr. Rafiq Rami, Dr. Ishaq, and Miss Inji, and the Free Fly team, because they're really the real troops behind the scenes in terms of having a very good quality recording and telecast for all of these webinars. So thank you on the behalf of myself, the behalf of all the speakers, and on the behalf of the organizers. And again, any educational activities bidirectional, it wouldn't have happened that way without the active participation of all the participants, irrespective of their location, their level of training. So I wanna thank all the attendees who made that a reality and make it possible. With that, I wanna pass to Dr. Tarek Al-Hussieny to get started with the last lecture of this series, and if you have any further updates. That's one of the topics that's my favorite, as Dr. Hussieny mentioned, not only because of just I decided to be a speaker on this topic, but it turns out that in the center where I am currently practicing, I get most of the referral for patients with adenomyosis for almost every indication, including assisted reproduction as well as reproductive surgery as needed. So with the centralized healthcare system in Canada, I happen to accumulate more experience over the past 8 years in this topic, more than what happened to me in my previous career. So adenomyosis is much more prevalent than what we think. First, here's my disclosures. So what I'm trying to share with you today is basically, does adenomyosis cause infertility? And if it is, what are the mechanisms that could be behind that? And if it is a cause of infertility, because we deal with infertility patients all the time, how can we diagnose it? And how can we link it to infertility and not treat it as a cofactor or an associated condition like anything else that could be in the female body at the time of treatment? And I would like to review with you the up-to-date treatment options, both in the assisted reproduction direction, I mean IVF, ICSI, and also touching on the uterine preservation surgery for patients who have significant uterine disease load that is not responsive to other treatments. So here it is. That's what you see under the microscope. If you look at the very top here, this is endometrium. And below everything in red here is the myometrium. And within the myometrium, you could appreciate the islands of the glands and stroma that's similar to the endometrium you see here, with extensive fibrosis and inflammatory reaction and myohyperplasia around it. So that's what makes the uterus bigger, painful, and tender. And that's what distorts the uterine cavity in patients with adenomyosis when you assess the cavity and a subtype of them. So generally speaking, the types of adenomyosis are either diffuse, as you can see here, the disease is involving the entire myometrium and extending even to the cervix, or it could be focal posterior, where you see here the posterior wall of the uterus markedly thickened compared to the anterior wall on this side, or focal anterior. You see the anterior wall here, the bladder is compressed, and the majority of the disease load is on the anterior. And by far, posterior focal disease is much more common than the anterior focal disease, but we see both. Sometimes the disease is very well circumscribed to the extent that will be mistaken for a fibroid, and that's what we call as an adenomyoma. And it's commonly to be corporeal, but I have seen it in the cervix. I've seen it on the cornua of the uterus where the tubes are. So there's no specific location that's considered to be the predilection site for focal adenomyosis. So if adenomyosis in mind, the first and the most important clinical question that you should answer to yourself, what type of the disease am I dealing with? Because that's going to dictate onto you the type of treatment, irrespective of the patient presentation, be it pain, bleeding, or infertility, or recurrent pregnancy loss. The second most important item that you have to decide upon is the depth of the disease. Is it deep, intermediate, or superficial? This is an old study that was done by a pathologist looking into uteruses after a hysterectomy. And he was able to link the severity of both pain and bleeding, dysmenorrhea and menorrhagia, to deep and intermediate disease. But in his series, superficial adenomyosis was not associated with menorrhagia and dysmenorrhea. However, that does not apply to infertility, because actually focal adenomyosis of the outer myometrium, which is according to this definition, has been recently identified as a specific risk factor for primary infertility by itself, irrespective of anything else, after controlling for maternal age, after controlling for concurrent endometriosis. If you have focal adenomyosis of the outer myometrium, according to this study that you're seeing in front of you, that came from one of the big centers in France, Charles Chaperon's group, which is very famous of its work in adenomyosis and endometriosis. So superficial disease does matter for patients with endometriosis, unlike patients with bleeding and chronic pelvic pain. So the symptomatology of the disease stands on two legs: the type of the disease and the severity of the disease. So that gives you an idea about the magnitude of the problem, and also can tell you about the predictable response for treatments, for different treatments. So patients with focal anterior or focal posterior may respond differently to treatment options, be it medical or surgical or assisted reproduction, compared to patients who have diffuse disease, or patients with focal adenomyoma, or patients with adenomyosis not distorting the endometrial cavity, as you would see shortly. So who is at risk? How can you just suspect and look carefully for adenomyosis? What type of patients? One of the best study that I keep quoting is the California teachers study that looked into 1,000 patients with adenomyosis, comparing them to close to 80,000 healthy controls. They found that adenomyosis is more prevalent in patients who have early menarche, short menstrual cycles, past contraceptive use, and if they have elevated body mass index. If you look into all of these factors, what is the common theme that gather all of this? It is local hyperestrogenism. All of the above is associated with local hyperestrogenism. So if there's increased estrogen activity in the body, that in itself can be one way or the other predispose certain type of patients to develop adenomyosis compared to others. The other group of risk factors includes parity, people who have a lot of deliveries, pregnancy termination, DNC or otherwise, prior uterine surgery. And the common feature for all of these risk factors is tissue injury and repair. So when you do a DNC, or you do a termination, or you do a myomectomy, or even a C-section, you injure the myometrium one way or the other, and that injury is always followed by healing process or repair process. So tissue damage or tissue injury and repair is a cofactor in the initiation of adenomyosis, at least seems to be. So again, the pathogenesis of the disease stands on two legs: local hyperestrogenism and tissue injury and repair. So with that in mind, the local hyperestrogenism, what it does, it increases the local peristalsis. If you have a break in the barrier between the endometrium and the myometrium, which is a junctional zone, that allows the endometrium to invade and implant itself within the myometrium and start growing. And all of that is hormonal responsive. So whatever happens on the normal endometrium would happen on the endometriotic implants within the myometrium, according to at least one theory, which is the invagination theory. I'm not going to go through all the theories of endometriosis, but that specific type or subtype is associated more with bleeding and pain. There is another phenotype where is invasion from outside, and that is the type that's associated more with infertility. So keep that in mind. So when that happens, that will change the environment inside the uterus by upregulating. When something is upregulated, everything in the body is based on genetic functions, controls every physiologic or pathologic function in our body. So when they are upregulated, means whatever products come out of this process is increased. So they upregulate the beta-catenin, CD68, IL-6, all macrophages. All of these are inflammatory. Inflammation means fibrosis. When you have fibrosis within the myometrium, which is below the endometrium, then you start to have suboptimal uterine environment, one way or the other. On the other side, it decreases everything good. All the receptivity markers or early placentation markers, the HOX gene family, the integrins, the leukemia inhibitory factor, and the IL-10. So basically, it disturbs everything. It increases everything that's bad and decreases very much everything that's supposedly good to have a healthy and physiologic uterine environment. Patients present with different presentations. I'm sure all of you are aware, but the top three are the chronic pain, endometriosis, chronic pain, infertility, and bleeding or heavy menstrual bleeding. You have to remember that close to 33% of patients with adenomyosis are asymptomatic. And that's really the subtype that appears from experience and from watching patients for some time. That is a subtype that appears towards the end of the reproductive lifespan. After a woman delivers 3 or 4 children, around the time she is transitioning into menopause. That's where you can see it by ultrasound, but there isn't anything really because patient is not infertile because she's no longer trying to get pregnant. Her menstrual functions are starting to wane in preparation for menopause. So unusual to have bleeding, although there are exceptions. And pain usually starts to get better towards the end of the reproductive lifespan anyway. So the suggestive triad of adenomyosis-associated infertility is dysmenorrhea specifically because it's originating from the uterus, not like other pain symptoms like dyspareunia or dyschezia or dysuria, heavy menstrual bleeding or infertility. If you have all three, think adenomyosis and rule it out. And the reason behind that is if you have pure endometriosis, that can cause pain and infertility, but rarely cause heavy menstrual bleeding. If you have fibroids, for instance, they can cause heavy bleeding. They can cause infertility if the cavity is distorted or they are blocking the tubes or disturbing the endometrial cavity or the endocervical canal, but they rarely cause pain unless they are complicated, like in scenarios where you have red degeneration or torsion of a fibroid, etc., etc. So when you have that triad, the incidence of adenomyosis in patients with dysmenorrhea and heavy menstrual bleeding and infertility is as high as 50%. So for every 2 patients having the triad you see in front of you, 1 of them will have adenomyosis, which is huge. So you have to pick it up and diagnose it. So what do you physically see when you examine the patient? Painful tender uterus, irrespective of how big the uterus is. It's painful and tender, usually midline. There is relative immobility. You may feel palpable nodules of endometriosis in the posterior cul-de-sac at the same time. And the uterus is relatively tender after excluding other causes of cervical motion tenderness. So that is kind of a brief introduction on the topic. How can adenomyosis cause infertility and poor obstetrics outcome? The first and the most important, I think, would be the cavity distortion. If you look into this MRI from a patient with adenomyosis, what you see here in front of you is the endometrium. This bright part is the endometrium. What's in front of it is the anterior wall. What's behind it is the posterior wall. The posterior wall should be as thick as the anterior wall you see here. You see how huge the posterior wall is. Not only that, but it's pushing the endometrium anteriorly in a way mimicking a type 2 fibroid or a cavity distorting fibroid. So with that, I want to caution you about something. The immediate first test that we do to evaluate patients with fitting the definition of infertility is an HSG. This is an HSG, hysterosalpingogram of one of my patients. You can see very much what seems to be normal triangular endometrial cavity, no acute distortion of the cavity. You could see the tubes on each side with immediate spill, indicating bilateral tubal patency. So one would say, if you're relying on this alone, that this is probably a normal uterus. But if you look into the MRI of that uterus, that is the exact same patient, no surprises. She has a huge adenomyosis or focal adenomyosis of the posterior wall of the uterus with significant distortion of the cavity of the uterus here. So don't rely exclusively on HSG to decide on the normality of the endometrial cavity, particularly if you have that particular triad that I talked to you about earlier. So just multimodality assessment and investigations would be quite useful. Somebody would say I would do a like a 3D ultrasound. Here is a 3D ultrasound of 3 patients with endometrial cavity here. This is before taking the 3D images. This is just the 2D image. You could see here that the cavity is more or less normal, but if you look at the 3D images here, that is a corresponding 3D image of each one of these cavities. You start to see shouldering, and you start to significant shouldering and irregularity of the cavity. We'll come back and talk about 3D ultrasound value and adenomyosis in a second. What else could be distorted? Vascularity can be distorted. So if there is tissue damage and repair, there is almost always angiogenesis. So angiogenesis is guaranteed in every part of the human body if there is any sort of tissue damage. And we agreed that there is a tissue damage. Ideally, you would aim for perfect angiogenesis that gives you normal, healthy blood vessels. But we know that angiogenesis that happen in pathological processes, and adenomyosis is not an exception, is a suboptimal angiogenesis. You have immature, unstable vessels, as you can see in this cartoon from this good paper. So it leaks. The blood vessels leak. When they leak, they cause bleeding. They cause fluid in the endometrial cavity. They cause subendometrial hemorrhages. They cause improper implantation site for pregnancy, or if implantation happened, they would be affecting the decidualization and the early placentation. So that, again, a change that can lead to suboptimal uterine environment. So the uterus is the natural incubator. It really mimics your incubator in the IVF lab. So similar to fibroids that distorts the cavity, when the adenomyosis is distorting the cavity, can affect the BCO2, humidity, and the pH of the uterine environment. Consequently, it may render it hostile or non-receptive for endometriosis. Sorry, for implantation. The other factor that change in patients with adenomyosis is uterine depth. And this is a study based on more than 8,000 fresh IVF cycles in more than 5,000 patients. And they found that pregnancy rate significantly reduced in patients with extremely short or extremely long endometrial cavity, less than 7 or more than 9. So this is normal range that you work within. If it is deeper than 9 centimeters, which is usually the case in patients with adenomyosis, then you would expect some sort of less success, be it with natural conception or be it with IVF, as this study documented. There are also multiple molecular endocrine changes, as I mentioned earlier. The mechanical stress that happened due to the enlargement of the uterus is similar to the stress that is associated with preterm labor. It triggers a lot of endocrine changes in the uterus, and I'm not going to go into the details of this, but you can look at the literature if you're interested. So the mechanical stress of the uterus itself does affect the peristalsis, the uterine contractility patterns, induces chronic inflammation, and impairs endometrial decidualization and decrease endometrial receptivity. So with all of what I said so far, that is the first key message that I want to share with you today. There is a convincing evidence that at least adenomyosis is an associated factor with infertility, and it does affect fertility treatments negatively. And we have to account for its existence in any patients, irrespective of the treatment scenario. So that is the first part. Next is the fact that adenomyosis, unfortunately, does not come by itself. It always, well, in a lot of patients or a lot of scenarios, it brings some other stuff with it. So the three common companions of adenomyosis are fibroids, endometriosis, and endometrial pathology. I'll spend a few minutes here. So this is a most recent study, actually, that looked into a population-based study, more than 33,000 patients in the United States. It's just published in the American Journal of Obstetrics and Gynecology. I want you to look here. The co-occurrence of uterine fibroid in patients with adenomyosis is 47%, and the co-occurrence of endometriosis in this patient population is close to 18%. I think endometriosis is even more than that 18% figure. I want to give you this example here, which is really can tell the entire story. You have a uterus that's very much the same size on these two patients. If you look into that uterus, there's a very well circumscribed fibroid that you see here, but also there is an increased junctional zone thickness, which is one of the criteria we use to diagnose adenomyosis by MRI. So this patient has adenomyosis and fibroids at the same time. The patient on the other side here, similar, very well circumscribed fibroid anteriorly and significant thickening with typical adenomyosis on the posterior wall of the uterus. But here, both pathologies, the adenomyosis and the fibroids, are distorting the cavity or touching the cavity. So if you treat one and neglect the other, you have done nothing, basically, for this patient fertility. You have to consider treating both pathologies. But when it comes to this type, whereas the phagotype 6 fibroid completely outside the cavity, this fibroid is meaningless when it comes to the fertility of this patient. And if there is no other factor, that adenomyosis in the uterus is part of the prognostic factors that we should account for when we treat this patient with adenomyosis. So according to this series, the adenomyosis could be associated with fibroids in approximately 1/3 of cases. The second is endometriosis. It depends on the study you look at. As I said, the study that I showed you earlier, the focal adenomyosis of the outer myometrium is associated with adenomyosis in up to 50% of the time. If you rely on MRI, 79% of patients with adenomyosis diagnosed by MRI has endometriosis. So how can you suspect this association? How can you tell that this patient with endometriosis have adenomyosis as well, or that patient with adenomyosis have concurrent endometriosis? Because again, treating one and neglecting the other may not give you the desired treatment target that you would like to achieve. So there are four things that I want to share with you in that direction. There are two of them that you know very well, and there are two that I want you to start to look at and start doing them in your practice. The two that you know about is concurrent endometriomas. If you have an endometrioma and you have the criteria for adenomyosis, done deal. You know that you have endometriosis as well. Or deep infiltrating endometriosis. If you have high resolution ultrasound to diagnose DIE, we can talk about that later at a separate talk. Then in this case, you have concurrent endometriosis in this case. The other two that I want to share with you today is a negative sliding sign that is indicative of cul-de-sac obliteration, and the question mark sign, which is one of the signs for adenomyosis uteri. So very much the positive sliding sign, anybody can do this in his office. This is a transvaginal ultrasound that I'm doing here. Is the bladder, here's the fundus, here is the cervix. When you see this fluid here, when you see fluid in the cul-de-sac, that tells you that the posterior cul-de-sac is not obliterated, at least at the level of the cervix. You could see the uterus moving really freely and nicely here at the level of the fundus and at the level of the cervix. This patient, I can tell right away there is no cul-de-sac obliteration. I can do laparoscopy at a shorter duration of time. I can counsel this patient about treatment without accounting for any tubal distortion of our tubes or patent by HSG. But if you go to this patient, you see there is something beyond the uterus here. That is very much a deep endometriosis nodule. And I'm moving right and left, there is no sliding. And lo and behold, there is an endometrioma here. So there is a negative sliding sign here at the level of the cervix and the fundus. And if you notice the uterus here, here's the endometrium. Here's the front wall, here's the back wall. Back wall is thicker, and it has other signs of adenomyosis. So this patient has adenomyosis, she has deep infiltrating endometriosis, and she has an endometrioma. So just briefly, we just published an article based on that sign only for patients where we did the sliding sign, and then we took them to the OR to do a laparoscopic surgery and tried to calculate the endometriosis fertility index. Endometriosis fertility index is one of the good prognostic tools that you could use in your practice to counsel patients not to waste their time if they have endometriosis trying to get pregnant or on their own or even with IUI, and they should go directly to IVF, or vice versa. Which type of endometriosis patient that you could encourage to continue to try on her own, particularly if other factors are good. We can talk about that in a separate talk. But what I'm trying to tell you here, if you have a negative sliding sign, that in itself can tell you that this patient have a poor endometriosis fertility index without doing laparoscopy with a sensitivity close to 80%. And you're more than welcome to read that article, and I'm happy to share it with you. That is the first sign, which is a negative sliding sign. That is, again, something you should look at in patients with anatomic factors of infertility in general, specifically adenomyosis and endometriosis. That is a question mark sign. I think all of you would see this and ignore it. Don't, moving forwards. Don't ignore it in your patients, because if you see that, what it means, you see this question mark sign here. So it's quite clear that the endometrium is taking the shape of a mark. Why it happened? Simply because you have adenomyosis on the posterior wall of the uterus here. You see how thick the posterior wall and how thin and normal the anterior wall is. And there is a pulling of the fundus here because of a deep infiltrating endometriosis or a concurrent deep infiltrating endometriosis here. So that what gives the uterus this question mark sign, and that is one of the signs of adenomyosis. So that's how you can suspect the disease. Again, for patients with focal anterior focal adenomyosis of the outer endometrium, you can tell in 50% of them you would have deep disease involving the colon as well. That may be of significance more for patients with chronic pain, but also it could be important for patients with infertility. So again, just to regroup, we are talking currently about the concurrent pathologies. We talked about fibroid, we talked about endometriosis. Lastly, I don't want you to neglect the endometrium. And up to 10% of patients with adenomyosis, you can have a polypoid adenomyosis, like you see here in the cavity of this patient with diffuse adeno. Although the cavity is not distorted, but there is a polyp here. You can have endometrial polyps, and you can have endometrial hyperplasia, which is much riskier for endometrial cancer for those patients, and could be a medically treatable condition if you pick it up early. We can talk about fertility preservation in patients with endometrial hyperplasia and endometrial cancer on a separate topic, on a separate day, sorry. So again, look at the endometrium and sample it, particularly for older patients, to rule out endometrial hyperplasia. So our first key message is that adenomyosis is at least associated with infertility and also impacts the treatment outcome negatively, be it conservative treatment or assisted reproduction in the form of IVF. Here's the second key message, which is adenomyosis-associated infertility is very much multifactorial. You have concurrent fibroids that you have to decide about whether you should treat them or not. You have concurrent endometriosis that you have to decide whether you should treat it or not. And there is a concurrent endometrial pathology that you should look at or exclude. And if it's there, you should decide whether you want to treat it along with treating adenomyosis or not. How do we diagnose adenomyosis, or at least how do we suspect adenomyosis? We're doing well with time. I don't want to drag here. So you can diagnose a lot of adenomyosis patients with ultrasound without even needing to do an MRI. And there's very limited role of hysteroscopy here. And what I wanted you to take is the MUSA criteria. This is a group that's called the Uterus Sonographic Assessment, Morphological Uterus Sonographic Assessment Group. They have a consensus statement to diagnose a lot of uterine conditions like the ethmoceal, or here is the adenomyosis. They have something about fibroids, and they have other stuff. But they decide about these signs of adenomyosis to make them easier for you to remember. That's how I remember them when I examine the patient without I need to pull the article in front of me. There are 3 things that are subendometrial that you should look for. There are 2 things at the junctional zone, and there are 2 translesional things that you have to look at. And there are some indirect signs. So the direct signs are the subendometrial lines and buds, the subendometrial echogenic islands, and the subendometrial cysts. These are the subendometrial category, part of it. And the translesional 2 are translesional vascularity by color Doppler or translesional fan-shaped striation. That leads to either a regular junctional zone and interrupted junctional zone. This is the most difficult to catch with ultrasound, and I rarely look for it, honestly. I rely on these 5. And these 7 or more criteria would give you either asymmetrical enlargement, which you can pick very easily, as I've shown you so many images so far where the posterior wall is thicker than the anterior wall, and rarely the anterior thicker than the posterior, or globular enlargement. The entire uterus is enlarged, and you can palpate it suprapubically. And I have a lot of patients who come and say, well, I could feel it, doctor, myself, above my pubic bone, and it's tender when I touch it. And it's typical. It's always in the midline, and it's not a fibroid. So remember that, 3, 2, 2, 2. So subendometrial, translesional, junctional zone, as well as the indirect signs of adenomyosis. I'm here showing you quickly how they look by ultrasound. These are the echogenic subendometrial lines and buds. You could see them here. And here is the hyperechogenic islands that are completely detached from the actual endometrium. They are not connected to it like the buds you see here. So they are separate islands. They are hyperechogenic. And the anechoic cysts between 1 to 6 millimeters throughout the myometrium, you can see them everywhere. 2 things to notice about this, actually. The first, this is really very much a mini chocolate cyst. This is the exact same structure and contents like the one you see in your chocolate cyst or ovarian cyst when you open it at the time of laparoscopy. And I'll show you some of the hysteroscopic contents of this shortly. That's the first thing you notice about that, or you know about that. That sign specifically can be temporary. So you may see it in one menstrual cycle. You may not see it in the next menstrual cycle because the lining here can burn out with time and becomes fibrotic. So it's no longer active with no active secretion of menstrual exudate within the cyst. So it could disappear. That is, again, the translesional fan-shaped striation. You see these dark lines going all the way back from the endometrium all the way to, perpendicular to the endometrium, all the way to the serosa. You can also in some books, they call it the rain in the forest sign. It's a good question for MCQ. So this is a patient with infertility who conceived and continued to have recurrent pregnancy loss after. You could see the gestational sac here with an embryo, with a fetal heart, and you could see the linear translesional striations here, the fan-shaped striation. And again, this patient developed retroplacental hematoma, as you can see here, and she went on to, the cervix starting to open, and she started to bleed, and unfortunately, she went on to miscarry 1 week later, which was was eubloid embryo. The second translesional feature by ultrasound is a translesional increased vascularity, which is by the color Doppler. That's very important You could see the hypoechogenic here. You could see the linear striation as well. You could see the hyperechogenic islands here all the way far away. You don't need an MRI to diagnose adenomyosis in this patient. You have at least 5 or 6 signs in front of you, and there is no need to waste a few $1,000 to spend, or a few thousand pounds to spend on an MRI for this patient to tell her that she has adenomyosis. You have the diagnosis at hand. So that is the actual Doppler flow of one of the patient, thick posterior wall, anterior wall very much within the normal diameter. And here's the endometrium, and you see the increased vascularity that's translesional. That's to differentiate it from what you see in patients with fibroid. So in fibroid, it's almost always circumlesional. It's around the lesion, it's around the fibroid itself, because the vascular mesh of the fibroid is around its perimeter. And these are pictures of the irregular and interrupted junctional zone. That in itself can make the uterus globularly enlarged, as you can see in this image, or asymmetrical enlargement with a thicker wall, posterior wall here, and thinner anterior wall here. How about 3D ultrasound? I think, personally, I don't think you need 3D ultrasound to diagnose adenomyosis, but there are some studies that says it has value, particularly in evaluating the junctional zone. But do you need the junctional zone sign to diagnose adeno by itself, apart from the other signs? Maybe not. So one of the systematic reviews and meta-analyses recently said that doing a 3D ultrasound doesn't add to the accuracy of the 2D ultrasound in diagnosing adenomyosis. But this is definitely controversial, and that type of evidence may change in the future with a better quality studies. When do we do MRIs? What is the role of the MRI? So MRI by itself has a good specificity and sensitivity up to 86 and 93%. It's particularly helpful when you have concurrent fibroid, or you are just misleading. I have many patients, the latest of which actually was last week, where she was referred for a fibroid surgery, but based on MRI, actually. MRI said fibroid. I looked at the images. I said, this is not fibroid. This is most likely adenomyosis. Called the radiologist, reviewed the images together, and lo and behold, it's adenomyosis. How did I know that? Because I have been beaten before by believing strongly in MRIs and then taking the patient to the OR, operating on them, yet to discover that this is an adenomyosis, not a fibroid. Fibroid surgery is easy to do, either open or laparoscopically or whatever approach you do, but adenomyosis surgery is difficult, and it needs special expertise with a certain number of cases under your belt to do them correctly without risking a hysterectomy. So long story short, if you are in doubt, do MRI. And that I would encourage you, if you have a facility where you can ask the patients to bring a CD for you and start looking at them. I'm not a radiologist. I did not receive radiology training, but looking at images from the patient, it's very much self-learning, like what you do with a initial abdominal or transvaginal ultrasound experience. With time, you'd accumulate the experience you need. With years of practice, you will be able to discuss it at least and prevent some of these problems from happening. Because I have seen hysterectomies happening unexpectedly because of bleeding, because of this misdiagnosis. Again, these are the 3 situations where I resort to MRI if the diagnosis is inconclusive, or ultrasound signs are negative to some extent, but there is a high clinical suspicion, if there's associated fibroid, and if I counseled the patient and she agreed or she wanted to go for an adenomyomectomy, which is uterine preservation surgery. I would never take a patient to do an adenomyomectomy without doing an MRI, because it really maps the uterus quite well for you. It tells you the extent of your surgery. These are 3 examples: same size uterus, pure fibroid, pure adenomyosis, a combination of both, adenomyosis posteriorly and fibroid anteriorly. How about hysteroscopy? Hysteroscopically, you can see any of that. Strawberry pattern, mucosal elevation, can see marked localized vascular pattern, or endometrial defects or trabeculations. Does negative hysteroscopy rule out adenomyosis? Absolutely not. So really, the role of hysteroscopy is its role to evaluate the endometrial cavity if there is any, like any other patient, nothing specific to adenomyosis. Here's a key message about the diagnosis that I want to share. So all starts with a good history and questioning. And if you have the triad of symptoms, pain, bleeding, the questioning is to decide if the patient is a high risk for adenomyosis, as I said earlier, whether there is any risk for hyperestrogenism or risk for uterine injury and repair, or if she has a triad of pain, bleeding, and fertility. And examination-wise, you have a painful, bulky uterus with cervical motion or uterine motion tenderness. If you have all of that, you do the ultrasound in your clinic. Most likely you get your diagnosis, I would say at least 70% of the time was experience. And if in doubt, order MRI. Moving to the last section of my talk, just checking here to see how are we doing with time. So here's a controversy, actually. There are some publications not showing any difference in pregnancy rates. And there are lots of other studies that showed from good clinics and good universities and good design, despite the limitation of every study, that they showed that there is a definite negative impact on IVF outcome when it comes to adenomyosis. Why this conflict? To me, because of three reasons. The first is that there's no RCTs, which is a gold standard to generate high quality evidence. Well, if we ask about the most heterogeneous type of studies that I have come across, actually it is the adenomyosis. Anything that deals with adenomyosis is very heterogeneous when it comes to the study population. You have everything is put in one bag, which is not true. Diffuse, focal anterior, focal posterior, fundal, cornual, circumscribed adenomyomas with cavity distortion, without cavity distortion. People start to pay attention to study design recently and recognize that adenomyosis has different phenotypes like fibroids. And that's, again, one of the reasons why we have conflicting messages or results. There's also mixing up of the different types. People do not take enough time to dissect the disease well in order to decide about what kind of disease are we dealing with prior to committing them to one study. One of the famous systematic reviews and meta-analyses that looked into the data said that there is a 28% reduction in the likelihood of clinical pregnancy at IVF and ICSI for patients with adenomyosis. Not only that, there's doubling of the risk of miscarriage as well. There is another study here that is actually prospective, came from St. Thomas group in the UK, that they looked in a multi-center design, prospective but not randomized, in 375 patients who attended for 3D ultrasound. And they looked into the 7 signs that I shared with you. Here's the pregnancy rate. 0 means there is no adenomyosis. 1 means 1 sign, 2, 3 signs, 3 signs, 4 signs. So there is a significant decline with each sign of the pregnancy rate and the IVF. And basically, with a 42%, the 42% pregnancy rate when there is no adeno in this patient population drops to 1/2 to 22% if the patient has 4 or more signs of adenomyosis, and to 13% if she have all 7 signs of adenomyosis. So counting these signs that you see by ultrasound is of a prognostic value. So you can tell the patient the story ahead of time, and you share with her actual and real chance of conceiving or not following transfer of your best embryo. Because if the environment is not good, believe it or not, they wouldn't get pregnant, unfortunately, in a lot of scenarios. So the cut-off level here, or the threshold, and that's the 4th key message, is if you have 4 or more signs. If you have 1 or 2, most likely, really, this is kind of incidental finding and would not affect 3, but 4, and that is the value and the importance of this study. And that's why I shared it with you, because it's one of the really good studies that you can use to answer clinical questions with a certain level of confidence. There is a recent meta-analysis, again, showed a 40% decrease in the live birth rate following IVF. However, this meta-analysis, one of its shortcomings is the fact that it didn't really dissect patients into focal adenomyosis versus diffuse adenomyosis. Another recent one in human reproduction update that showed that adenomyosis is associated not only with lower clinical pregnancy rate, live birth rate, and increased miscarriages, but also the obstetrics outcome of those patients is poor, with increased likelihood of preterm deliveries, small for gestational age, high likelihood of C-sections, and pregnancy-induced toxemia. Treatment. So is there any role for medical treatment in patients with adenomyosis? Really, if you're looking overall, irrespective of the treatment they used, using medical treatment to improve their fertility outcomes, be it spontaneous or IOI, it most likely not. And we can draw some conclusion from the systematic review that looked into pre-treatment, medical pre-treatment in patients with endometriosis that showed that there is no fertility value of pre-treating the patients with the different measures. It remains the question of GnRH, actually, pre-treatment with GnRH. And I just want you to differentiate between two types here of pre-treatment. The pre-stimulation pre-treatment, before you stimulate the patient, or the pre-transfer pre-treatment. I want to discourage this one, and I want to encourage using this one more liberally, particularly with the fact that we have better outcome with frozen embryo transfers than fresh transfer this lately. Basically, that is the systematic review, the updated Cochrane review that is done by the same group, actually, that did the first one that was published in 2006 based on 3 RCTs to say that pre-treating patients with endometriosis specifically, not adenomyosis, but you can extrapolate given the commonality between the two, improves the outcome. But people experiences says that if you pre-treat them, particularly if they have poor ovarian response, you will get a very poor response. However, recently they revised their systematic review by adding 5 more RCTs, so a total of 8 RCTs. And it showed that there is no significant difference in clinical pregnancy rate, and there's no difference in the miscarriage rate or the mean number of oocytes retrieved in patients with endometriosis when you pre-treat them with GnRH. There is one study here that I want to share with you. It's about adenomyosis. That is pre-transfer, pre-treatment. And I do that a lot because basically, here's a scenario, a clinical scenario. Patient with adenomyosis, you did good stimulation. You ended up with 4 good quality blastocysts on day 5. Let's assume the best and say that you have a facility where you're doing BGTA and all 4 are euploid. So, okay, cavity looks normal, but she has adenomyosis, which is making the posterior wall of the uterus huge, or the cavity is kind of borderline. You went ahead, you transferred one embryo, didn't get pregnant. You transferred the other embryo, didn't get pregnant, or did get pregnant and miscarry early on in the first trimester. The question is, if this patient tells you that I would never have another IVF cycle, I don't have the money, would you go ahead and transfer the other 2 embryos and repeat the prior failure or consider something else? One of the considerations is to pre-treat with GnRH analogs prior to transfer. And one of the other considerations that I will share with you in a select group of patients is doing adenomyomectomy and then pre-treating. Why pre-treating for transfer? Because I don't want them to get pregnant quickly. Adenomyectomy is extensive surgery. I want the uterus to heal well. And at a minimum, I would ask them to wait, not to try to get pregnant on their own for at least 6 months. So anyway, long story short, lots of patients after retrieval and creating embryos and freezing them, they will end up waiting anyway. During that waiting time, be it waiting for any other reasons or waiting for healing from a surgery or waiting for because they are frustrated and their first 2 transfers didn't work, there is an opportunity here to pre-treat them with GnRH because you're not stimulating the patient in between, so it's not going to affect your your outcome negatively by decreasing the number of retrieved eggs. You're only transferring embryos. So that study actually showed a significant improvement following frozen embryo transfer if you retreat the patient with GnRH analogs. You can use Lupron 3.75 milligrams monthly for 3 months. I use it for up to 6 months if the patient underwent adenomyomectomy. There are some data still that pre-treating before stimulation can improve the outcome, both in endometriosis and adenomyosis. Some people still believe in that. And this is kind of a different debate that we can discuss at a different visit. So simply what I can tell based on what I know and what I do in my practice is that pre-stimulation doesn't seem to improve the outcome so much, but pre-transfer may be a good thing to consider. However, further validation is necessary to make it like a routine practice. Lastly, the role of fertility sparing surgery or adenomyomectomy. Here is a list of the different surgical procedures. Hysteroscopic resection you can put them under 2 major categories: uterine preservation surgery, or if the family is completed and the patient is looking for definitive surgery. Hysterectomy, you don't do as a fertility doctor. But I want to warn you against uterine artery embolization and radiofrequency ablation. I have seen patients who are infertile that were offered uterine artery embolization and radiofrequency ablation for adenomyosis as a treatment. Please don't, because the prognosis is worse after these. For patients with infertility, their bleeding specifically may get better, but not pain get worse, and there is no proven fertility benefit. So when it comes to the uterine preservation surgery, there is a hysteroscopic resection. I recommend against that, except in few exceptions, and I'll share one with them of them with you shortly. You can do adenomyomectomy surgery. HIFO is getting popularity, which is the high intensity focused ultrasound or MRI guided ultrasound. That's most of the work is coming from China because it's FDA approved there or approved there for use in those patients. So there are some case reports about its value. And obviously, if the uterus is not really repairable or something that you can throw into any embryo, there is a uterus transplantation, which is currently experimental, but you never know what the future would carry. So that's something you can consider. That's how you do adenomyomectomy. Probably some of you have seen that video before. So it's simply different from the fibroid surgery. You bisect right in the middle of the uterus and you go all the way to the endometrial cavity. You have to open the endometrium intentionally in order to do good repair. And then, yeah, that's me talking. So let's mute that. So you mark healthy myometrium here. You see this marking is demarcating what's healthy and what's disease. And in what's disease, we try to excavate each hemiuterus. This is 1/2 of the uterus. And you're going to remove each quadrant separately. And you're going to excise it and repeat it in all 4 quadrants until you get it completely resected. Here is moving to the other quadrant here. And after that, you start repairing. Different techniques of repair, but the 3 or the 4 key points that if you're going to do this surgery, you have to do linear, layered, non-overlapping repair with or without triple flap, according to the thickness of the 2 flaps that you develop after resecting the disease itself. This is one of my patients actually who managed successfully to get pregnant after that surgery. Here's the surgery, the uterus after the completion of the repair through mini laparotomy, and this is interseed on top of the uterus to prevent scarring. Here's a hysteroscopy after adenomyomectomy for 2 of my patients. You see this, I told you I'll talk to you about that later. You notice that brownish stuff, watch what comes out of it. When you cut it with a scissor, you see something like chocolate material, similar to what you see coming from the ovary, actually. So that uterus after adenomyomectomy looks better than that uterus to me, actually, because there's a lot of subendometrial hemorrhages here. There's trabeculations. You will see them here. Here's a trabeculum, a big diverticulum here towards the fundus. This is a tubal ostia. And there's a lateral diverticulum here, lateral to the tube. This is not another tube, it's a diverticulum. And lo and behold, this patient got pregnant and delivered. Actually, this patient was a better uterus, didn't. So this is another patient. That's where endometrial, like hysteroscopic resection be of value. This is a patient where I did an open adenomyomectomy on her, and she came back with a recurrence of bleeding. And she has one frozen embryo to be transferred. She transferred multiple, no pregnancies. And then actually I did a hysteroscopic resection. You notice here I'm using a MySure device. I'm not using a resectoscope because the surface area on top of the resectoscope of the adenomyosis is much more than the surface area that you're gonna get with a fibroid resection. Remember, fibroid is a one cell. So you're digging into a cavity through digging into the cavity of the fibroid endometrial. You're getting the fibroid out, the uterus will heal nicely. You wouldn't lose any endometrium. But here, if you use a resectoscope, you will be actually resecting a lot of endometrium. And I feel a little nervous about that because those patients will have some sort of percreta after, if they get pregnant. So this patient actually, after resection with the resectoscope, which doesn't use any current, she went on to conceive. Actually, it was her last embryo. She's very lucky. So this is my experience so far with adenomyomectomy. I've done probably more than 25 now, but the other 9 or 6 that not included in this series are due to bleeding and pain, not due to infertility. I have close to 6 or 7 pregnancies so far. All of them actually ended up with delivery after 34 weeks, and they required a C-section. So who is a candidate for adenomyomectomy? If the patient has severe adenomyosis that's refractory or unsuitable for medical treatment. It's preferable for patients for focal disease. I counsel patients with extensive disease that's involving the entire uterus differently, and I try to discourage them. If the patient is using her own eggs, preferably age under 39. But if they are in a country where they can use donor egg, then there's no upper age limit. If there is a uterine evidence of uterine cavity distortion, and if there is evidence of poor reproductive outcome, these are all candidates. That's a systematic review that we did, that we looked at that. But what I want to tell you from here, the risk of uterine rupture is up to 17% when we pull the data together, and I'll talk to you about that later and how to minimize it. Again, that's the person who invented this. Osada from Japan published his experience of more than 2,000 patients, close to 400 pregnancies, and he reported 6% likelihood of uterine rupture after adenomyomectomy. Who is going to be at risk of uterine rupture? It depends on the removal method of the adenomyosis, the degree, the uterine defects, whether they develop hematoma after treatment or not, hence the importance of good repair, and if they have infected, and if they went pregnant, to go pregnant right away after the surgery without waiting long enough for the uterus to heal, and obviously the skill and the experience of the surgeon. So in the majority of the uterine ruptures, the 23 cases that I shared with you, almost always in every single patient, they used some sort of electric current to cut the muscle of the uterus with the disease. So don't use Bovi or the electrocautery, don't use MySure, don't use any of these devices. Just use a simple scalpel, because that is a risk factor for uterine rupture, either spontaneous or if the patient usually you wouldn't allow them to labor. Laparoscopic versus open. Well, I'm just quoting to you what the expert said here, the person who invented that. Again, adenomyomectomy is extremely difficult to perform by laparoscopy, laparoscopic surgery, only because the extirpation of the adenomyoma should be carried out under palpation and delicate suturing with multi-layer closure. You really do a lot of suturing, which you can do well by laparoscopic surgery. However, given what I told you that up to 50% of those patients have adenomyosis, and endometriosis at the same time, Usually I start most of these cases laparoscopically and free the uterus, because the uterus sometimes is stuck to the colon. You can't really do good job liberating the colon from the uterus and getting access to the posterior wall and doing the adenomyomectomy. So start laparoscopic, treat the endometriosis, and then you do a fan steel incision, small or large, it depends on how big the uterus is, and do the adenomyomectomy. So in conclusion, ladies and gentlemen, I hope I did not bore you today. The diagnosis is possible by transvaginal ultrasound using the MUSA criteria. And if in doubt, order an MRI. Focal adenomyosis of the outer endometrium by itself is associated with primary infertility specifically. There is a 28% lower pregnancy rate, and there is doubling of the miscarriage rate in patients undergoing IVF. Concurrent pelvic pathologies are common in patients with adenomyosis. So remember, endometriosis, fibroids, and polyps or intrauterine cavity. Two of them must treat, actually. The endometrial pathology has to be treated before infertility, and the fibroids if they are distorting the cavity. But if they are not distorting the cavity, there may be no need to treat them. In addition, the role of adenomyomectomy, as I said, is poorly defined with lack of high quality data, and we need long-term follow-up. Pre-treatment with GnRH before controlled ovarian stimulation does not seem to improve pregnancy rate, but before embryo transfer, it's a maybe, so that's something you can consider. When indicated or in the right scenario, adenomyomectomy would really improve pelvic pain and abnormal bleeding and may possibly improve their fertility. If you're going to do that, pregnancy rate appear to be higher among patients with focal disease. The majority of my experiences with focal disease, my limited experience, I shouldn't say that I have a big experience with that, while a higher incidence of uterine rupture was reported after surgery for diffuse. So most of the uterine ruptures are after surgery for diffuse adenomyomectomy, and if you use electric current, as I said earlier, but not with a focal disease. Lo and behold, I haven't seen a rupture in the cases I did. With that, I want to thank you very much for your attention, and I'm happy to take questions. Sure.
The first one is in patient with multiple XC cycles. Is there any risk of developing adenomyosis because of tissue handling, as you mentioned?
Well,
as a complication of multiple ICSIs.
Well, during multiple ICSI, you are not puncturing the uterus. So you're puncturing the ovary to retrieve eggs. Embryo transfer is a very benign process. You're just putting a simple catheter inside. So I don't see any injury happening to the uterus at the time of ICSI. If there is anything, if we call it injury, it would be the egg retrieval process or egg harvesting rather than the uterus. And I haven't come across any study that tells me that repeated IVF cycles in general, with or without ICSI, doesn't matter, would increase the risk of adenomyosis.
Okay. What about the evidence of the presence of adenomyosis in women who have bleeding with contraceptive methods?
Well, we have to differentiate between two things here. If you have, does this patient have bleeding to start with before you put her on the contraceptive method, be it birth control pills or a Mirena IUD? We know all progestin methods by themselves increase the likelihood of irregular bleeding and spotting in a lot of patients, particularly in the first year after use. So we use these methods to treat heavy bleeding in patients with adenomyosis, particularly if not severe, right? For instance, Mirena IUD has been described in some studies. One of them actually was done in Assiut by Professor Omar Mamdouh Shaban, that it can improve bleeding in those patients. Though in my experience, they do improve bleeding in patients with adenomyosis if the cavity is not distorted and not deep. If the cavity is distorted and deep, I think it will be a waste of time to try this, but you can try it if it's the only option. The only medical treatment that I have seen improving bleeding in those patients will be GnRH analogs with add-back therapy. So you give them progesterone of some sort as an add-back, like norlutate or norethindrone, in addition to the monthly or the 3 monthly if they are long-term treatment. Also, the newcomer, the GnRH antagonist that we have here in Canada, I'm not sure if it's available in Egypt or not, the Elagolex, on its highest dose, which is 200 milligrams BID, the one that we use here. But back to the question again, there are two separate problems here because we have to, if you have an IUD or you have a Mirena or you have progesterone medicated method, first of all, before saying that it is due to the adenomyosis, you have to look into the patient history prior to using this method. If she has pre-existing bleeding, so most likely the ongoing bleeding is a failure of treatment. She's not responding to what you give her in terms of birth control or in terms of hormonal treatment rather than secondary to the birth control method or the hormonal treatment itself.
Okay, thank you. The next question is, you mentioned the MUSA criteria for ultrasound diagnosis of adenomyosis. Which of them would you rank first, or would you rank the pathognomonic for adenomyosis?
Well, there are two answers to this question. Let's start with a simple one based on evidence. We can say none. You cannot identify one method to be, or one sign to be, hey, I see that's adenomyosis. But practically speaking, let's think about it. When would you get a question mark sign? You would get question mark sign when you have a distortion of the transformation zone or junctional zone, when you have significant thickening of the posterior wall and concurrent deep endometriosis, deep infiltrating endometriosis. And that is most likely, like the patient I've shown you earlier. I can show you this again if you wish. Or any patient with significant asymmetry of the uterus. I can tell you that if you look carefully, you will find at least 4 or 5 more signs. So if you measure the anterior wall and the posterior wall separately, and the posterior wall is like 50 millimeters or 5 centimeters, and the anterior wall is 1.5 or 2 centimeters, very much you're dealing with an adenomyosis. If you look for the rest of the signs, you'll find them. The same for the question mark sign. Also, I find that the majority of the patient where I personally saw the question mark sign in the uterus, they have a lot of other signs of adenomyosis. And there's actually, it reminded me of a study that was published from Italy, actually, that looked into the question mark sign individually. And they reported around 70 to 75% sensitivity and specificity to diagnose adenomyosis, where they have a question mark sign, they took the patient for an MRI, and then they compared, and they were able to pick adenomyosis based on that sign. But it's one study and a small number, so you cannot really build a lot on that. But at least it can capture your attention. Oh, here is a big asymmetry between the anterior and posterior wall. Let me look for the other signs. If you have a good quality machine, you will find them.
Okay. You mentioned endometriosis fertility index.
Yes.
Can you just enumerate what is in this index? I know that this is a totally different topic, but just to let
no problems at all. No problems at all for the benefit. Well, I think in a simple way. So endometriosis fertility index is a validated method to predict pregnancy in patients with endometriosis for both spontaneous conception and intrauterine insemination. And there is some data about IVF as well, and we can come to the IVF data later. So in terms of how authentic that index is, it is authentic. It is in the guidelines for the American Society of Reproductive Medicine, and it's also in the guidelines for the World Endometriosis Society. It's recommended to be used for patients with endometriosis. What it is, there are two major components for this index: a historical component and a surgical component. Just to simplify it, historical component is number one, the patient age. Number two, duration of infertility. Number three, whether the patient has been pregnant or not. So these are the three factors. And there is a scoring from 0, 1 to like the Apgar score. Then laparoscopically, you look at the adhesions, the fimbria of the fallopian tube, and the ovary. And there's a score for each one of these. It's very easy, very simple to use. And there's an app for it. And if you look into your computer and to type endometriosis fertility index, you will find even something online now available that you can calculate that index yourself. So you plug these numbers according to your patient. If you have a 36 years old with 3 years history of infertility, never been pregnant, so she's right away scoring very poor on the historical factor. Our score will be, let's say, 2 or 3. And then you take this patient to do a laparoscopy. She has tubal occlusion, or she has a poor fimbria, or lots of adhesions, and there's periovarian adhesions. So very much score of 5. If a score of 5 or less, then the chance of this patient getting pregnant on her own is low. Very low, actually. We're talking about 5 or 10%. The chance of this getting pregnant with insemination, because at the end of the day, intrauterine insemination depends on the ovum pickup. This tube should be functional and should pick up the egg from the ovary at the time of ovulation. It's very poor. So what can help those patients? One of two things: either taking them directly to IVF, or you just try to correct the endometriosis fertility index surgically by restoring their anatomy. You can't change their history. You can't correct their age. You cannot correct their duration of infertility, and you can't change the fact that they've never been pregnant. So it's a combination of both historical factors and surgical factors. What we did actually, what I encourage you to do, because in order to do the classic endometriosis fertility index, you have to operate on the patient. And currently we are tending not to operate on patients with endometriosis because we don't want to touch the ovary. We don't want to destroy ovarian reserve, and we want to optimize their outcome with IVF by maximizing the egg yield. So that's when we try to substitute the surgical factors with the sliding sign. So if the sliding sign is negative, it tells me that there is cul-de-sac obliteration, which means that the tube is adhesions. Actually, in our paper, we looked into all 3 components, and there is a concordance with, I did not really go into the details because of time. You can see ovarian mobility by ultrasound, whether the ovary is moving or not. So they can tell you if there's periovarian adhesions. Obviously, you can see endometriomas. You can see hydrosalpinx, if there is hydro secondary to the endometriosis, which we see quite commonly. So that in itself can give you an indirect idea. You can't say that it's a classic. That our findings need to be validated in a bigger study, but actually did not really fail us. We see complete cul-de-sac obliteration. She's poor historically. Tell her, listen, if you really want to get pregnant, we have to go for IVF right away. Or if she has concurrent pain, she doesn't have the means to do IVF, then tertiary care surgery in a tertiary care facility with somebody who has experience in both advanced endometriosis surgery as well as reproductive surgery to try to optimize our tubal functions. So that's very much in a nutshell what the endometriosis fertility index says.
As I understood from your answer, that you think that even the endometriosis fertility index might change in the future.
Correct.
Might change in the future to adopt these new signs, the question mark sign, the negative sliding sign, instead of putting the risk of going to the operation room, especially in patients who have had 1 or more previous laparoscopies before.
That's true. And actually, theoretically, but until we see studies that are validated to tell us, but it will continue to be a good tool to use in practice, particularly if there is a decision for surgery.
Okay, you touched the uterine artery embolization. And you mentioned that we don't use them in infertile women.
Correct.
And you mentioned that the bleeding is increased with the uterine artery embolization. So what would be the indication if the patient, the three symptoms of adenomyosis, the heavy menstrual period, dysmenorrhea, and the infertility? So don't use them in infertile women, don't use, or the bleeding will increase. So what do you think the role of uterine artery embolization?
Just a small correction, I may have said it wrongly, actually, because uterine artery embolization decrease, doesn't increase. But it's counterproductive when it comes to the fertility factors. Specifically, there are lots of reports about diminished ovarian reserve following uterine artery embolization because of inadvertent embolization of the blood supply, be it the main blood supply coming from the ovarian vessel or the ascending branches of the uterine artery that travel through the suspensory ligament of the ovary to supply the ovary. And also there are reports about poor decidualization after uterine artery embolization, meaning that the endometrium may turn to be less receptive. And those patients are more likely to develop abnormal placentation. And also there are reports about preterm birth. That's why it's not my favorite when it comes to patients who are infertile. But if the patient completed her family and she doesn't want further children, it is an option that you can consider for treating heavy bleeding and to solve heavy bleeding and pain. And the recurrence is very high, though, up to 50% recurrence. They may get temporary relief for a few months or a few years, and then they start to bleed again later or to have pain again later, particularly if they are young.
Okay. The next question is about the wedge resection or the USADA or the adenomyomectomy that you mentioned. Would it increase the implantation rate in women undergoing assisted conception?
That's a very important question.
Pardon?
I want to strongly condemning the use of wedge resection for adenomyomectomy in patients with adenomyosis. And USADA procedure or adenomyomectomy is a completely different surgery from wedge resection. Wedge resecting the uterus is a recipe for a big uterine defect and for leaving a ton of adenomyosis behind. You would have very much done nothing but harm to this uterus. So wedge resection is a big no-no in my books when it comes to uterine preservation surgery. What you do is careful extirpation and excavation of the adenomyotic tissue with an attempt and trial to preserve every single myometrial cell, at least 1 centimeter towards the serosa and 1 centimeter towards the endometrium in order to get adequate thickness on the posterior wall with adequate repair. Wedge resecting the uterus is very much to wedge resecting the ovary. We already stopped doing that long time ago. I think we should stop doing wedge resection of the uterus for patients, particularly for patients who are contemplating pregnancy. If you don't know how to do adenomyomectomies and you want to learn how to do adenomyomectomies, there are some YouTube videos that you can watch. You can watch a person who does them, but please don't do, I would discourage you from doing 2 things surgically. 1, wedge resection. 2, or actually 3 things. 2, using any electric energy, like cutting the uterus with a bovie. 3, doing mass closure after removing the uterus. It has to be layered, careful closure with lots of suturing to avoid dead spaces and hematomas. So for those who are considering to do that surgery, get yourself ready before you go and do them, because you can cause more harm than good.
Okay, are you ready for more questions?
I am with you until all the questions are done. It's the last day, so we have to treat people well.
Okay, the next question is, are there any studies of giving heparin to increase the success rate in adenomyosis? I think the person who asked this question means after assisted conception.
Well, okay. Well, heparin to treat adenomyosis or to improve adenomyosis infertility, I see no hypothesis here. I see no rationale actually for why would we give heparin for those patients. If there is another indication for heparin treatment, like antiphospholipid antibody syndrome, patient is lupus anticoagulant positive times 2, 12 weeks apart, or beta-2 glycoprotein 1 positive for prior history of DVT, first degree relative, and then she has one of the congenital thrombophilias, then like any other patient, there could be a role for a combination of aspirin and heparin on those patients. But for heparin treatment in general to improve poor outcome in patients with IVF is considered to be one of those additives that we have a lot of data now to discourage people from using them.
Okay. Is there any mechanism to explain miscarriage in adenomyosis?
There are theories and hypotheses, but not a specific one is the one. To me, I think the poor desexualization and early placentation is the main cause, because that is a suboptimal endometrium, particularly if there's cavity distortion, very much similar to the fibroid. Actually, to me, it's much more worse than a fibroid, because fibroid at the end of the day is a one-cell disease. It starts in one cell. This is very much a blanket involvement of the endometrium. And as we know from our classical education, that majority of implantations happen on the posterior wall of the uterus. And unfortunately, that's the wall that's affected the most with adenomyosis. So there is a suboptimal endometrium, and those patients one way or the other.
So it means that we do have two factors, the endometrial and the cavity. I mean the space occupying and the endometrial receptivity decreases.
Correct. Well, there are lots of changes that can happen in the lining of the uterus in patients with adenomyosis. I didn't go into the details again because of time. One of the most important ones is progesterone resistance. So we know progesterone resistance is a common feature in patients with endometriosis. That we know also adenomyosis patients has evidence of progesterone resistance. And that can have implications, particularly with luteal phase support in patients with who are undergoing IVF cycles.
So this brings us to the next question. What do you think about the use of high-dose progestagens or Dynogest in treatment of adenomyosis?
Very good question. We use it a lot actually here.
And this is the question of Mahmoud Alim. He asked always good questions.
Yeah, Mahmoud is to the point. Thank you, so basically, it depends on the patient phenotype. If there is a concurrent endometriosis, that's typically my first line treatment. So what happens when I start with Dynogest or Visan, as it's called here, 2 milligrams, they may get better with pain first, and to a little extent with bleeding, particularly if they are hemorrhaging. So what I do in those patients, I increase the dose to 4 milligrams instead of 2. If they continue to bleed, which I see it a lot, unfortunately, I just stop and start GnRH analogs with add-back therapy, because it's going to be a waste of time. Visan is a very good medication for pain, but it's not any different from any other hormonal method for bleeding. So if you have the bad combo of pain and bleeding, Visan may work for a short duration, but not for a long time. If you cannot use GnRH analogs, what I do for those patients actually, if they cannot afford GnRH because it's expensive and they don't have insurance to cover, or if it's not available, I use two types of progesterone. I give them the Visan, and I know that it will be good for their pain. And I ask them to be patient, not to judge it, except after 6 months of treatment. And concurrently, I put a Mirena IUD in the uterus. So the Mirena will help with the bleeding locally. There is some benefit to the bleeding from the Visan, and there is an added benefit of the Visan for pain. So this combination works for some patients as well.
Yes, but for sure this is not.
But
for
definitely none of the
infertility.
above would work for infertility.
Yes. Okay. Does adenomyosis affect ovarian response in ICSI or in IVF in general?
Not if there is no concurrent ovarian disease. We said already that up to 30–40% of the patient will have concurrent endometriosis. So if they have concurrent endometriosis and it's affecting the ovary, then the effect on the ovarian reserve is not secondary to the adenomyosis, but it's secondary to the concurrent pathology, which is endometriosis.
The next question is there any specific treatment as adjuvant before and during ICSI in luteal phase in women with adenomyosis, different from the normal luteal phase support?
Well, luteal phase pre-treatment, pre-stimulation, or luteal phase post-transfer?
No, post-transfer.
Post-transfer.
During stimulation, is there any specific adjuvant?
Before stimulation, I said. Before stimulation.
During and after embryo transfer.
Well, during stimulation, I am not aware of any. Transfer-wise, we use two types of progesterone in general, and more towards the higher end for patients which is using both transvaginal and injectable progesterone. The protocol that's been published by the Shared Growth Group, you can look at that, look that up to look at the doses. But that's very much what we use for almost everybody. It's not different from other patients without adenomyosis, but it is, if there are situations where you're using only transvaginal and you are selective in using the injectable, I think that's one of the patients subtypes where you have to use injectable in addition to the transvaginal as well.
I think this might be the last question. It is actually a nice question. I liked it. In the operation you show how you color the normal myometrium and adenomyosis. ازاي بتلون ده؟ بتجيب قلم في الماستر وبتلون ولا دي حاجة مخصوصة بتعملها عشان تبقى with infection control?
Good observation. So this is a marker pen actually that comes with the sterile surgical kit that we use it to mark the skin when we do the incision for the residents so they wouldn't cut above or below. So it's sterile, so it comes in the kit. But really you don't need to use anything if you make a good judgment by saying I'm going to leave at least 1 centimeter of tissue close to the serosa and 1 centimeter close to the endometrium on the other end that you did not see in my video. So I color it so I will be getting better help from people who are scrubbing with me so they know exactly where am I going and which direction. And it's a good guide actually, particularly in the earlier cases before you accumulate experience. So there are sterile pens. You can sterilize any pen and use it, no problems.
I'm sorry, this will be the last one.
Yeah, no problems.
Is there a role for extensive progesterone support to decrease the abnormal contractility of the uterus in adenomyosis patients, whether for spontaneous pregnancy or in assisted conception?
Well, we're talking here about empiric therapy with progesterone, if we're talking about assisted conception. And we're talking about luteal phase support. I answered the part that pertains to the luteal support in the previous question. When it comes to spontaneous pregnancy, I use progesterone support liberally for patients with recurrent pregnancy loss and patients with, I know the concept of luteal phase defect is very much instinct based on some of the studies, but patients with a short luteal phase, less than 12 millimeters, let's say they get a cycle every 23 days, or patients who start to bleed, who start to have spotting before their actual flow. Let's make it easy for people. A patient with a 28-day cycle, and her period lasts for 5 days, because before her period start, before those 5 days start, she started spotting for 2 or 3 or 4 days before that. So there is a total of 5 days of bleeding, that's her normal, and there's a 4 days before that where she's spotting. These 4 days is premature breakdown of the endometrium of those patients. And most likely it's secondary to poor luteal phase support. If there is no local disease in the uterus, that's the cause. For patients with adenomyosis, there is a local disease, so that can be attributed. Whether giving luteal phase support in those patients would fix it or not, I am not sure. I don't think so, because the pathology is still there. But for patients without uterine pathology, I think it may help in some patients. So I started, if she has a typical 28-day cycle, 3 days after ovulation, because I tell the patients all the time, remember, progesterone, we use progesterone as a contraceptive, and we use progesterone to improve conception. It's all about the timing. If you use progesterone at the wrong time, that's going to prevent you from getting pregnant. So use it for the correct indication at the correct time. So basically, for patients who are trying to get pregnant, at least 3 days after ovulation. So if they ovulate day 14, you should not start it before day 17 or 18. They carry on with the progesterone until the day of their expected period. If they get a period or do a pregnancy test and it's negative, they stop and they can start all over again with the next cycle. If they are pregnant, I keep them on it until week 10 of pregnancy, when the transition from the corpus luteum to the placenta is complete.
Okay, but would you increase the dose of progesterone in the luteal phase after embryo transfer in patients?
For the person who are asking this question, what do you use in terms of progesterone?
I don't know.
What dose do you use?
Yeah.
So we use 50 milligrams of injectable progesterone oil every other day or every third day, in addition to 200 milligrams TID vaginal for the majority of patients.
So you yourself don't increase this dose in patients with adenomyosis?
Not any different from the usual protocol that we're using for all of our patients.
Okay. Thank you very much, Professor Bedaiwy. It was a pleasure meeting you tonight and throughout this year. We appreciate very much what you have done and your time and effort for organizing such an excellent series of webinars. I think that our attendees, wherever they are, benefited a lot from them, and we are looking forward to more collaboration with you and your team. Thank you very much.
Thank you, Professor Tarek. It's my pleasure, and thank you for the team, and thank you for all the audience. We really appreciate your presence with us throughout the past few months. And you have a wonderful evening, and all the very best.